Uh, Hi, Secretariat, please check and confirm if my voice is clear and my video is quite visible.
Yes, sir. Yes, sir. Perfectly fine.
Okay, perfect. Thank you so much, Shivang. Really appreciate. Well, a very good evening to all of you, and very warm welcome on behalf of AUHD. I'm Dr. Pavan K. Gupta, a part of Executive Committee of AUHD and the Secretary AUH Haryana branch. It gives me immense pleasure to host this 6th edition of OQ Healthscapes, which is a wonderful initiative driven by the Delhi branch and none other than our Senior Vice President, Dr. Rajiv Kumar Jain, has been kind to drive this initiative, and we have been really thankful to him. This is one of its kind, once in a month initiative, wherein we get updates from local, regional, as well as global level regarding environment and occupational health. So, as I can see, we have attendees and parties panelists as well. And once again, I thank all for sparing their time and joining this webinar. And without any further delay, I would like to introduce our very own Dr. Rajiv Kumar Jain. And he is Senior Vice President of AUHD. And we have been really blessed to have him with the Delhi branch, such a renowned and internationally acclaimed speaker that we have with us, and we always feel proud of Dr. Jain's achievements and accolades that he has collected across the globe. Just to name a few, he's the Senior Consultant Health, Indian Railways, New Delhi, 40 years of experience in health and hospital administration, Fellow Award of Indian Public Health Association, Fellow Award of Association of Environment and Occupational Health, Delhi. He has published and presented more than 145 scientific papers in national and international conferences. It's a huge accomplishment, and we always feel proud of it. Fellowships, scholarships by World Health Organization, National Institutes of Health, USA, Canadian Society for International Health, International Clinical Epidemiology Network, and International Society for Priorities in Healthcare. First Secretary and Registrar of the Delhi Medical Council, Member Managing Committee, Scientific Committee on Epidemiology in Occupational Health of International Commission on Occupational Health, ICOM. And the list is quite vast, as we all know. I want to keep it up to here, but I can definitely go on, and then it will be probably a session in itself. And with that, I would like to invite kindly our very own Dr. Rajiv Jain sir to please take the stage and enlighten us with his thoughts. Over to you, Dr. Jain.
Good evening, friends. So today, once again, the last Friday of the month, we have gathered to get an update on the occupational and environmental issues regionally, nationally, and across the globe, so that we keep ourselves updated on the latest happenings in the field of environment and occupational health that have happened during the last 1 month, or those events in this field that are likely to happen in the next, say, 1 fortnight or so. So today we shall start with an event which is very important, and which is one what every healthcare professional, and especially occupational health professionals, should be aware of. That is the World Health Statistics Report which was released by the World Health Organization about 1 week or so back. To be accurate, 17th of this month, this report was released. Also important to understand that these days, the World Health Organization is having its World Health Assembly, which is entirely virtual. And this year, we are all lucky. We are all lucky to get all the deliberations online on the World Health Organization website. So it is a true World Health Assembly that any professional interested in any matter connected with World Health Organization can just go online to the World Health Organization, click the link to World Health Assembly and listen to all the deliberations. And if you miss some deliberation, you can watch the recorded version on that website itself. So as I was talking earlier, the World Health Statistics Report. Next slide, please. This is important in many respects because the World Health Statistics Report this year also includes global COVID-19 excess mortality estimates. As you know, the mortality is not accurate across the world. The data is not recorded correctly. So it has to be estimated. Right from developed world to developing countries, the error, it keeps on increasing between actual data and the reported data. So the mortality figures they always remain underestimated. So it's important to know how much is an underestimation and then predict what is likely to be the real situation. So to begin with, World Health Organization, it's released the state of the world's health assessment in the World Health Statistics Report 21. The report presents the latest data on more than 50 health-related sustainable development goals and triple billion target indicators. As you remember, there were 50 health-related sustainable development goals, and there was a target of triple billion to reach in the context of the universal health coverage. The 2021 edition includes preliminary estimates for global excess deaths attributable to COVID-19 for 2020 and the state of global and regional health trends from 2000 to 2019, 20 years data. It also focuses on persistent health inequalities and data gaps that have been accentuated by the pandemic, with a call to urgently invest in health information systems to ensure the world is better prepared with better data. As of 31 December 2020, preliminary estimates suggest the total number of global deaths attributable to the COVID-19 pandemic in 2020 is at least 3 million, representing 1.2 million more deaths than the 1.8 million officially reported. This is, all of us should understand that 1.2 million deaths more than the actual deaths reported. So the estimate is 3 million deaths. So 1.2 million is the gap assessed by WHO in this report. Based on the excess mortality estimates for 2020, 3.4 million deaths currently reported by WHO are likely a significant undercount, with true figures at least 2 to 3 times higher. This is again very significant for all of us to understand that based on the excess mortality estimates for 2020, the 3.4 million deaths currently reported by WHO are likely to be a significant undercount, with true figures at least 2 to 3 times higher. 2 to 3 times higher. So you can understand the devastation to mankind due to COVID-19 pandemic. Next slide, please. Every country is facing challenges to report COVID-19 deaths. and WHO is working with all stakeholders to refine statistical models and obtain accurate counts. The global and regional estimates of excess mortality will be followed by country estimates, which shall be released later in this year. So you will have to wait for these figures where country estimates will be given. The COVID-19 pandemic poses major threats to population health and well-being globally and hinders progress in meeting the Sustainable Development Goals and World Health Organization's triple billion targets, with 90% of countries reporting disruptions to essential health services and 3% of households spending more than 25% of their budget on healthcare in 2015, universal health coverage is at greatest risk of falling behind. Remember, universal health coverage also includes occupational health services. COVID-19 disproportionately impacts vulnerable populations, with those living in overcrowded settings at higher risk. Lack of data disaggregation contributes to unequal health outcomes, with only 51% of countries including disaggregated data in national statistical report. So the message is that we need to collect disaggregated data to know where the vulnerable populations are and how much is the contribution of each subset of population. Next slide, please. Global life expectancy at birth has increased from 66.8 years in the year 2000 to 73.3 years in 2019. With healthy life expectancy, which has gone up from 58.3 to 63.7 years. Greatest gains are being made in low-income countries, primarily due to rapid reductions in child mortality and communicable diseases. Another important data is regarding global tobacco use. Global tobacco use is down by 33% since 2000, but adult obesity is on the rise, with up to a quarter of populations in high-income countries, which is obese in 2016. Along with this, non-communicable diseases have made up 7 of the 10 causes of death worldwide in 2019. So non-communicable diseases make up a substantial portion of deaths worldwide last year. WHO has partnered with Microsoft and Avanet to develop a new state-of-the-art World Health Data Hub to improve access to data, which will be the real data that is visible to all. So with this, I will take you to an interactive website of Global World Health Statistics Report, where you will actually be able to see these summarized reports, summarized observations in real time, so that it's not much more useful to you. This is, if you go to the World Health Organization website, and if you go to World Health Statistics Report 2021, there is a link to a World Health Statistics 2021 visual summary. If you go down this website, you will see a dynamic picture on different parameters that are available in the World Health Statistics Report. If you go down, impact of COVID-19 on population health, keep going down. And this is important. Household overcrowding increases, then preventive COVID-19 behaviors decrease. If you look at the bottom, hand washing and extremely overcrowded, more than 5 people per room is in dark blue, moderately overcrowded is in yellow, just 2 to 5 people per room, and uncrowded is less than 2 people per room. If you look at this, adherence to hand washing decreases with overcrowding. Similar is the observation to mask wearing. and least is physical distancing, simply because there's no space for physical distancing. Mask wearing also suffers, but hand washing is the highest which is maintained. But yet, the higher the size of the room, better is the adherence to hand washing, mask wearing, and physical distancing. So overcrowding is an extremely constraining factor in controlling COVID-19 behavior or adopting preventative COVID-19 behavior, which is a cause for the disease transmission in overcrowded settings. We could go down further and see the further observation in the dynamic visual summary. Now we come to health inequalities. Look at this. Just go up. Yes, this is sufficient. This is across the world where are the people living in higher proportion of years in good health. If you look at 2019, in low income, they were spread across. Just press to 2000 again. Lower and middle income, they are in the center, but low income, they are disaggregated across. That is percent of healthy years in life expectancy. And an upper middle, they are also spread in the center, 57%. High income, they are also in the center. But when we go to 2019, what has happened? The progress is occurred in low income. The more dots, the dark blue dots are in the center. Then they were spread out across. So there has been improvement in life expectancy and leading causes of death and disability by sex, by country, and by region. So percent of healthy years in life expectancy has improved across the world because of the low progress in the low income countries in the last 20 years. Let's go down further and see what has changed in the last 20 years. Now we come to burden of disease. Look at this. This is in low income countries, and it is non-communicable disease. Please don't press anything now. Non-communicable disease in light blue. Green is communicable disease, and injuries are in dark blue. Now, if you see from 2000 on the left to 2019 on the right, you will find in low income countries, the contribution of communicable disease is predominant. But you'd also see injuries have increased from 2005, and they contribute substantially a good number in 2019. Also, you would have also seen the rise of light blue color from 2000 to 2019. That is non-communicable disease have increased. But if you go to other than low income countries, now go to drop down and low middle income countries, low middle. Now look at this. Look at this. Injuries have remained horizontal. The contribution of non-communicable disease has increased, but at the same time, communicable diseases have gone down in the top 10. Now we go to high middle income, upper middle income. Look at the change. Injuries have come down from 2000 to 2019 at the bottom, and also communicable diseases have contributed very little. And light blue is so dominant, that is substantial non-communicable diseases are there in upper middle income. Now we go to high income countries. Now look at this. Where is the dark blue? Where are the injuries? Hardly anywhere. So they have had substantial interventions where injuries do not contribute substantially to the top 10 causes of death. Also, you will see the minuscule contribution is by communicable diseases, but substantial contribution is by non-communicable diseases, as was in 2000. So the contribution by developing countries, low income countries has been substantive. And overall now we see all the income countries, low, middle, lower middle, upper middle, as well as high income have substantive non-communicable disease. So the priorities have changed in the last 20 years. Accordingly, we need to have our intervention and our occupational health practice. The focus has to be on non-communicable diseases. Let's go down further and see. This is important. 3 parameters: malaria, tuberculosis, and HIV incidence, which are rates globally. Look at the left. Left is malaria. Center is TB incidence per 1 lakh people. And right is new HIV infections per 1,000 uninfected people. Now, what do we see? Africa is green. The highest malaria, tuberculosis, and HIV, new HIV infections are in Africa. And also, only in Southeast Asia, tuberculosis is very, very prominent. If you see the purple line in the center block, this is tuberculosis, and purple is Southeast Asia, major component contributed by India. So India needs to do substantive intervention in reducing tuberculosis burden. If you look at all the sizes of the columns, you will see the Eastern Mediterranean, which is in red. Tuberculosis is still a problem, and also Western Pacific region is also having a problem of tuberculosis, but much less than Africa and Southeast Asia. And all the regions are facing problem of, Africa is facing all 3 problems together: malaria, tuberculosis, and new HIV infections. And that's why you must have seen how it is paying the price. Price is underdevelopment and poverty. Next, let's go down further. This is mortality rate by cause per 1 lakh people that is unintentional poisoning. Unintentional poisoning, you see, highest is in high income countries, but it has decreased, but the highest decrease you will see in upper middle countries. And if you see the differential, males are higher than the females, all regions, all lower middle, upper middle, and high income. If you see the gender gap in high income is huge, gender gap is minimal in lower middle income. If you see the other parameters, this is suicide. Look at the rates in suicide. So what do you observe? You still observe the differences in gender. Number 1, males higher than females, and highest high income group. Next, see the other parameters. Road traffic. Now you look at this. Highest road traffic are in low income countries. Look at the difference between the low income, lower middle, and upper middle, and high income. High income very low, but also you should observe males suffer more for road traffic accidents in low income countries than females, and the differential between male and female is substantial in low income countries. All the regions, lower middle, upper middle, and high income, except low income, the rates have decreased, but in low income countries, the rates have increased or stabilized. For females, it is almost stable, but for males, it is increased. Let's see the other parameters. It is homicide. Look at homicide. What do you see? Upper middle countries have the highest homicide rates, though rates have gone down, but the highest decrease has been in upper middle countries, but still they are the highest amongst all. And the homicides amongst males is highest in all the regions, all low income, lower middle, upper middle, and high income. Also, you must see in the left, low income countries, substantive contribution of homicide is still prevalent, while high income countries have very low levels of, already low at 2000, still they maintain very low levels of homicide in high income countries. So the price of underdevelopment is shown in homicide. Next, lower down, that is unintentional poisoning, bottom. This is right. So what you see, low income countries highest, and the lowest in high income countries, and lower middle and upper middle in between. But you'll see the reverse. Upper middle have higher unintentional poisoning, lower middle have lower than upper middle countries or even lower than low income countries. Let's go down further, see what further information is available. This is interesting. Health manpower, number of people for every single nurse and midwife. If you see, the highest number of dots are in Africa, 973. For every single nurse midwife, he has to serve 973 persons. But look at Europe, 129, Western Pacific 271, Eastern Mediterranean 609, America is 121, and Southeast Asia 409, where India is. Now we go to physician. Number of people for every single physician. Look at the gap. Africa 3,623, and second is Southeast Asia 1147. Number 3 Eastern Mediterranean 914. Number 5 is Western Pacific 531. America is 353, and Europe is 232. So the best in terms of physician availability is Europe, and the worst is Africa, then Southeast Asia. Let's go down further. This is data, how many countries use the disaggregated data in national health statistics reports. If you see globally, 133 countries, low income countries, only 26 countries, lower middle income countries, 41, upper middle, 34 countries, and high income, 32 countries. So the countries in low income regions have to make their disaggregated data efforts much more effective in the days and months or years to come. Let's go down further and come to the conclusions. So, as I told you earlier, between 2000 and 2019, major gains in health have occurred at global level, resulting in the increase in life expectancy and healthy life expectancy at birth, with the fastest improvements in low-income countries, reflecting predominantly the remarkable progress made in reducing child mortality and major communicable diseases. There has also been a steady decrease in mortality from suicide, homicide, unintentional poisoning, and road traffic, with men at higher risk of dying due to injuries globally. Since 2020, the COVID-19 pandemic threatens to derail the progress made towards the Sustainable Development Goals over the last 20 years, while underscoring existing inequalities in health within and between countries. Tracking any changes in health-related indicators is critical on all fronts to identify where investments would be more impactful for improving population health and tackling the root causes of inequalities. Putting inclusiveness and equity at the heart of all recovery responses to create a fairer and healthier world. From unmasking obscured health inequalities to informing policies and prioritizing interventions, disaggregated data can drive communities to achieve health equity. With more timely and reliable data, progress can be monitored more effectively towards all health goals and priorities at national, regional, and global levels. With clock ticking, countries need to double down on the investment in their health information systems to better prepare for future outbreaks and ensure rapid progress towards achieving the triple billion targets by 2023 and the health-related sustainable development goals by 2030. These are the last goals, next targets. Now let's go down the presentation again and touch another topic of interest during the last 1 month in the field of occupational environmental health. Next slide. Next slide. Yeah. An interesting article has been published by a lady in Occupational Health, Occupational Medicine Journal. An insight from a NHS occupational health physician during COVID-19. And this is a quote: for many years, the work of National Health Service occupational health departments across the country has been invisible. This we are talking of UK. Occupational health services have been regularly confused with occupational therapy or merely vaccination providing and needle stick injury management teams. I believe this crisis has demonstrated the wide-ranging skills of the occupational health professional as a strategic advisor on risk assessment and management, and consequently as a crucial cog in ensuring staff and patient safety. This is her own feeling and this is her own experience during the COVID-19 pandemic. Next slide, please. This is the article I was talking about, and what she says is very, very important for all of us to understand that occupational health has been undervalued in the NHS, even in UK has been undervalued for years. Yet this pandemic has allowed OH to prove its agility and value. And my OH department is no different. And she's further saying, perhaps as importantly, the skill of the consultant in occupational medicine has never been more in need by the NHS. We were faced with a situation where we had to make difficult decisions about staff with underlying health conditions that did not fall in the self-shielding group. The evolving evidence made the creation of a single fit for purpose risk assessment tool a real challenge. The tool needed to be adapted quickly and creatively to incorporate new vulnerabilities. The decision had to be consistent, fair, and objective despite the constant flux of evidence and policy, balancing the needs of the individual with that of our National Health Service. And she concludes with a hope that the challenges presented by this crisis will demonstrate that occupational health should be recognized as a clinical specialty in its own right, with its own dedicated funding stream to secure its future. This is very important observation and hope that she has made. And this is for UK. What she says, the challenges presented by this crisis will demonstrate that occupational health should be recognized as a clinical specialty in its own right, with its own dedicated funding stream to secure its future. As chair of the NHS Health at Work network, I continually encourage doctors to specialize in occupational health. I hope that our next generation of young doctors will recognize occupational health as an attractive specialty and career choice, as she did 25 years ago. And she is Shriti Patani. Shriti Patani has written this in Occupational Medicine Journal and is published recently. Very important observation from her own experience during the pandemic. And we in India need to think what the occupational health professional has contributed in managing the pandemic in our country, and how occupational health practice is going to change in the post-pandemic world, how we add value to the community, to the organization, and to the health services at large. Let's go and take up another topic now. If you recollect, every year, 5th of June is World Environment Day. And World Environment Day is celebrated on 5th of June since 1974. And it engages governments, businesses, and citizens in an effort to address pressing environmental issues. For too long, we have been exploiting and destroying planet's ecosystems. Every 3 seconds, the world loses enough forest cover to the size of football pitch. And over the last century, we have deprived half of our wetlands. As much as 50% of our coral reefs have already been lost, and up to 90% of coral reefs could be lost by 2050, even if global warming is limited to an increase of only 1.5 degrees centigrade. Ecosystem restoration means preventing, halting, and reversing the damage, to go from exploiting nature to healing it. The World Environmental Day will kick off the decade of the ecosystem restoration, a global mission to revolve billions of hectares from forests to farmlands, from top of the mountains to the depth of the sea. Only with healthy ecosystems can we enhance people's livelihoods, counteract climate change, and stop the collapse of biodiversity. Above all, the World Environment Day offers a global platform for inspiring positive change. It pushes for individuals to think about the way they consume, for business to develop proper models, greener models, for farmers and for manufacturers to produce more sustainably, for governments to invest in repairing the environment, for educators to inspire students to take action, and for youth to build a greener future. Everybody living in this planet, in this moment in time, can be a part of generation restoration. And important, every World Environment Day is hosted by a different country in which official celebrations take place. And if you recollect, last year it was India. Now this year it is Pakistan, where on 5th of June, the World Environment Day celebrations shall take place. So stay connected and watch the rolling out of World Environment Day from Pakistan all across the world. Next slide, please. Every year we have a different theme. So 2020, 2019, 2018, and 2017, we had different themes, and we keep on adding to our efforts towards World Environment Day. Next slide, please. Ecosystem restoration. If you look at it, could you make it large, please? Control
sure,
plus,
sir.
if you see.
Yeah.
Yes, go ahead and then move it down. Okay. Yeah, that's it. From forest to wetland to coast, we all depend on healthy ecosystem. Next, rates of discussion and solutions. If you see, I would like to draw your attention to over 4.7 million hectares of forests, an area larger than Denmark, are lost every year. That's one football field. Solutions are ecosystem restoration is a global undertaking at massive scale. It means repairing billions of hectares of land, an area greater than China or USA, so that people have access to food, clean water, and jobs. It means bringing back plants and animals from the brink of extinction, from peaks of mountains to the depth of the sea. But it also includes the many small actions everyone can take every day: growing trees, greening our cities, and rewilding our gardens, or cleaning up trash alongside rivers and coasts. Could we go to next slide, please? Yes. Now, another important event which occurred during the last 1 month is the estimate by the World Health Organization and International Labour Organization, which in relation to stroke and ischemic heart disease and the effect of long working hours has on heart disease and stroke and deaths due to these two events, these two diseases or group of diseases. Long working hours have led to 745,000 deaths from stroke and ischemic heart disease in 2016, which is a 29% increase since the year 2000. This has been observed in the latest estimates of World Health Organization and the International Labour Organization. In a first global analysis of loss of life and health associated with working long hours, WHO and ILO estimate that in 2016, 398,000 people died from stroke and 347,000 from heart disease as a result of having worked at least 55 hours a week. 55 hours a week, 398,000 from stroke and 347,000 from heart disease. Between 2000 and 2016, the number of deaths from heart disease due to working long hours have increased by 42% and from stroke by 19%. So if you work for long hours, more than 55 hours a week, the incidence, the deaths rates increased by 42% in last 16 years from 2000 to 2016 and 90% for stroke. This work-related disease burden is particularly significant in men. 72% of deaths occurred among males, people living in the Western Pacific and Southeast Asia regions, and middle-aged and older workers. Please look at these findings. If you are men and in Southeast Asia region, that is India, your chances of dying due to ischemic heart disease increase substantially. And if you are middle-aged or older, still more likelihood. Most of the deaths recorded were among people dying in the age of 60 to 79 years who had worked for 55 hours or more per week between the age of 45 to 74 years. So this is a crucial observation for all of us to understand, to have work-life balance. Next slide, please. With working hours now known to be responsible for about 1/3 of the total estimated work-related burden of disease, it is established as the risk factor with the largest occupational disease burden. This shifts thinking towards a relatively new and more psychosocial occupational risk factor to human health. And this is very important for all of us to understand. This is a major shift in our thinking. It is a new, relatively new, and it is more psychosocial occupational risk factor, long working hours. So please change your occupational health practice. The study concludes that working 55 or more hours per week is associated with an estimated 35% higher risk of a stroke and a 17% higher risk of dying from ischemic heart disease compared to working 35 to 40 hours a week. This is again very important finding. Further, the number of people working long hours is increasing and currently stands at 9% of the total population globally. This trend puts even more people at risk of work-related disability and early death. Another important observation is over here. Each of the observation is important to make us change our occupational health practice and our work culture. Next slide, please. The new analysis comes as the COVID-19 pandemic shines a spotlight on managing working hours. The pandemic is accelerating developments that could feed the trend towards increased working time. The COVID-19 pandemic has significantly changed the way many people work. This was said by Dr. Tedros Adhanom Ghebreyesus, who is the WHO Director General. He also says teleworking has become the norm in many industries, often blurring the boundaries between home and work. In addition, many businesses have been forced to scale back or shut down operations to save money, and people who are still on the payroll end up working longer hours. No job is worth the risk of stroke or heart disease. Governments, employers, and workers need to work together to agree on limits to protect the health of workers. Working 55 hours or more per week is a serious health hazard. This was said by Dr. Maria Naira, who is the director of the Department of Environment, Climate Change and Health at the World Health Organization. It's time, she also said, it's time that we all, governments, employers, and employees, wake up to the fact that long working hours can lead to premature death. And what we need to do, all three stakeholders. Next slide, please. Governments, employers, and workers can take the following actions to protect workers' health. Number one, governments can introduce, implement, and enforce laws, regulations, and policies that ban mandatory overtime and ensure maximum limits on working time. Number two, bipartite or collective bargaining agreements between employers and workers associations can arrange working time to be more flexible, while at the same time agreeing on a maximum number of working hours. And third, and not the least, employees could share working hours to ensure that numbers of hours worked do not climb above 55 or more per week. So all three observations are practical actions which all of us, governments, employers, and workers, must do sooner than later. Otherwise, we are looking at a future epidemic, future sudden increase in deaths due to stroke and ischemic heart disease. And these are important observations. We must change our occupational health practice and recommendations to the management, and we must engage all stakeholders so that these facts are made visible. And another important data that I would like to show you is the next slide. All these observations have come out of 2 systematic reviews and meta-analyses of the latest evidence that were conducted for the study. Data from 37 studies on ischemic heart disease covering more than 768,000 participants and 22 studies on stroke covering more than 839,000 participants were synthesized. So this is data of data, meta-analysis, and this is systematic. So this is evidence for action for all occupational health professionals and all employers and all governments. The study covered global, regional, and national levels and was based on data from more than 2,300 surveys collected in 154 countries from the year 1970 to 2018. Look at the strength of the evidence. It is not isolated. It's based on real data of real people in real environments across the world. So please remember, all the observations that are mentioned just now need to be taken with lot of strength of evidence and implemented on a war footing. Each of us need to prevent these preventable deaths, and risk factor needs to be controlled. Next slide, please. Another important event that all of us should look for is on 7th of June, World Food Safety Day is celebrated on 7th of June every year. Next slide, please. What National Institute of Nutrition of ICMR has done, it has brought out COVID-19 and food safety as a booklet form. I'm sharing with you important observations from that document made out by ICMR, National Institute of Nutrition, based in Telangana, Hyderabad. First is precautions to take when buying foods. Carry sanitizer, that is 70% alcohol, when you go out to purchase food to clean your occasionally. While buying fruits and vegetables, maintain distance from the others at market, shop, and mobile vendor. Do not go shopping if you are unwell or sick. Always buy fresh fruit or vegetables that are not bruised or damaged. Carry your bag and touch only those foods that you want to buy. Avoid touching surfaces, carts, and shopping baskets at the vending sites. While buying meat, prefer freshly chopped and minced meat or chilled frozen meat. Keep the food items away from your body when carrying from the market. Put the purchased food items in your shopping bag. After reaching home from the market, wash your hands with soap and clean water for 40 to 60 seconds. Do not store or leave the food outside of your home or in car or garage, as it could lead to food safety issues like temperature abuse and pest exposure. And last, sanitize food packages, not directly on foods, applying alcohol-based solution and or clean water. Open the packages, discard external packs into a dustbin, wash hands with soap and water, or sanitize. Next, food safety in COVID-19, precautions to take while handling the foods. Wash vegetables and fruits thoroughly under running water, or put a drop of 50 ppm chlorine in lukewarm water, dip them and wash. Do not apply disinfectants, spray, sanitizer directly on fresh produce. Spraying chemicals on vegetables and fruits makes them all the more harmful. Do not use detergents, sprays, or sanitizers to clean fruits, vegetables, meat, or any other raw food. Store fruits and vegetables which require perishable in refrigerator. Wash the milk packet thoroughly with water before use. After washing, wipe it dry. Otherwise, external surface water could pour into the pan. Always clean the meat at the end after cleaning fruits and vegetables. Wash and clean the meat under running tap water. Avoid taking broken and damaged eggs. Store eggs in refrigerator. Next, please. This is food safety in COVID-19, precautions to be taken while getting foods from our online delivery platforms. When ordering food from delivery platforms, use contactless delivery option where food packets are left outside your door and customer is informed on call. In case contactless delivery is not possible, make sure that there is 1 meter gap between you and the delivery person. When handling delivered food items, open the package and discard external packing into a dustbin. Wash hands with soap and water or sanitize hands with an alcohol-based sanitizer. Empty the food content with tongs, ladles, or spoons into clean serving dish. Discard the food package holding food. Again, wash hands with soap and water or sanitize. Consume hot foods hot and cold foods cold. Next slide, please. This is the last food safety and COVID-19 precaution to be taken when preparing foods at home. Keep food preparation surfaces, equipment, and utensils clean. Use separate chopping boards, knives, utensils, containers for vegetables, fruits, and flesh foods, raw and cooked food. Wash your hands for at least 40 to 60 seconds with soap and water while shifting from handling vegetarian to non-vegetarian food or raw to cooked food to avoid cross-contamination. Cook food thoroughly. For later consumption of cooked food, such as gravies, curries, and rice preparations, store them in safe temperatures, refrigerated at 4 degrees centigrade. These foods should be reheated thoroughly before consumption. No need to thaw them to room temperature before eating. Wash kitchen counters and slabs and stove thoroughly with water and detergent every day. Cut your nails regularly and do not handle food when you are unwell. So this shows that food safety and COVID-19 are important relative concepts and they go hand in hand. You cannot separate the two. But there are certain questions that arise. I will take a few questions and the answers to those questions. Next slide, please. Number one is, does COVID-19 infection spread through food? There is no evidence to date of viruses that cause respiratory illnesses being transmitted via food or food packaging. Coronavirus need living host, either animal or human, for its multiplication. Second is, does eating meat cause COVID-19 infection? The answer is no. There is no scientific evidence to prove that COVID virus can spread through meat. However, meat should be cooked thoroughly and safe handling practices must be followed before its consumption. Another question that comes, does eating garlic, ginger prevent COVID-19 infection? The answer is there is no scientific evidence to prove that eating garlic, ginger prevent COVID-19 infection. However, they are known to have compounds that can improve immune function. Another question comes is, does eating ice cream and frozen foods spread coronavirus infection? The answer is there is no scientific evidence to prove that eating ice creams and frozen foods spread coronavirus infection. Another question that comes is, does COVID-19 spread from a food worker handling my food? The answer is a sick person should not cook or handle food. If the food handler is sick and you come in close contact with the person, you may be vulnerable. Next slide, please. Do probiotics help prevent COVID-19? Probiotics are live microorganisms which help improve gut health and improve immune function. However, there is currently no evidence to support the use of probiotics to prevent or cure COVID-19. Can adding pepper to your soup or meal prevent COVID-19? The answer is no. There is no evidence that adding hot peppers to your food can prevent or cure COVID-19. Do herbal teas or herbal supplements prevent or cure COVID-19? There is currently no evidence to support this. Can micronutrient, that is vitamin and mineral supplement, prevent or cure COVID-19? There is not enough evidence to come up with any guidance on micronutrient supplementation for prevention of COVID-19 in healthy individuals or for treatment of COVID-19. Micronutrients, if consumed from food sources like fruits, vegetables, nuts, and whole grains, can play an important role in well-functioning immune system and play a vital role in promoting health. So this is the last final slide that I have, and we have today covered a wide spectrum, right from occupational World Health Statistics report to the experience of an NHS occupational physician to the study on WHO and ILO report on diseases of long working hours in relation to deaths due to stroke and ischemic heart disease, and the World Food Safety Day and World Environment Day theme this year. So we have covered in about 1 hour what we could in nutshell. I hope the issues that we have handled today were relevant to you. Thanks for patient listening. If you have any questions, I would love to.
Thank you. Thank you so much, Dr. Jain, for those illuminating thoughts and wonderful update, rather quite informative. And absolutely, as you have summarized very well, I was trying to summarize it. I was thinking that probably I'll be putting it across, but then you have already done it. Nonetheless, I'll touch upon that. Thanks to you for sharing those thoughts on WHO's ongoing assembly, important points. Definitely the role of occupational health from Ms. Padani, some important aspects that she has mentioned, and definitely updates for related to World Environment Day. And long working hours, quite interesting it was, though we all keep listening about it, but we know that except for multinationals and few Indian organizations, we have 6 working days in India, as we see. And if we just put a simple calculation of 9 hours per day into 6, it goes to 54 hours a week, Monday to Saturday. So we are very close to those 55 hours. And I think it's time that we need to deliberate, as you have rightly put across, and entire globe is working on it, and policies are being, it is being advised to make policies by government. So we, to avoid those heart and brain complications, cardiac diseases, as well as stroke, to prevent that. NCDs definitely have taken a significant toll, and they are increasing, as you have already shown. Thanks for sharing that. And the final one was a very informative and interesting Q&A that you have just shown related to food safety and COVID. We look forward to more updates related on as World Food Safety Day is on 7th of June, and also World Environment Day. We'll see a lot of things coming up, but these things are definitely supporting us and helping us in keeping ourselves abreast on the latest issues, latest developments, and information. Really appreciate spending your time and sharing those thoughts.
Dr. Pavan,
Yes.
Dr. Akhilesh amongst the attendees has raised his hand.
Yeah, and
he has
sure,
to
Dr.
be-
Jain. Yes, yes.
He
And
has to
before
be
that,
taken as a panelist now, so
Yeah,
that he
yeah,
can
and
ask his question.
yes, yes, I'm doing that. And before that, hands were raised by Dr. Kishore Parekh. So I'm going to allow him to please, Dr. Kishore Parekh, please unmute yourself, and please go ahead, the question that you had.
Hello.
Yes,
Yes,
we can
Dr.
hear you,
Kishore.
Dr. Parekh. Yes.
Yeah, sir, it is. There is no question. It was very wonderful and very informative. As usual, sir, you are charming in your presentation. Thank you so much, sir.
Thank you so much, Dr.
Right.
Kishore Parekh. Over to Dr. Akhilesh. Please, Dr. Akhilesh, you can go ahead and ask your question.
It was really fantastic session. I think today we have covered, like, there was a lot of breadth in the number of topics that we have covered. So I have just a couple of points. So I would like to ask it in single breath. So the first point is regarding the tuberculosis, as sir was showing regarding the burden of tuberculosis in developing countries. So my first question would be, what do you think the tuberculosis progression would be in India in the coming years? So there are two aspects. One is because of the generalized increase in the immunity as it pertains to diet on different things. Will TB go down, or like in America, they have already unmasked. So once we are off the respiratory hygiene, will the TB again come back with force? That's my first question. And my second question is, sir shared a wonderful article regarding industrial health or occupational health physician in the hospitals. As far as I know, the entire India, we are hiding behind the Schedule 2 and Schedule 3 of Indian Factories Act, only catering to the hazardous industry primarily. So even though occupational physicians are needed in hospitals, we are not getting to that level. And second thing is, when it comes to white collars, as sir was saying, the disease burden. This is my second part of. This is my second question. That is with regards to white collars. Again, as we are hiding behind Schedule 2 and Schedule 3, our focus is still in the very primitive stages of occupational health, and we have not been able to move past to the white collar workers, be it any organization, as far as many organizations as I have seen. And work-life balance is, again, it is messed up when it comes to our Indian context, because you were saying 54 hours. In fact, I would beg to differ, because it's more than 54 hours, considering 2 to 3 hours that Indians put in transportation,
Yeah.
transporting themselves to the workplace. So, sir, I wanted to ask you I'm coming to the core of the question is, the Schedule 2, Schedule 3 lawyers, and there are lots of cases. That's why the focus is mainly on the physical aspects and the chemical aspects of the work, or the blue collar workers are in focus. But there is no such organizations, or there are no such cases. Being in the competitive world that we are, there is no collective bargaining on the part of white collars. So I think that is one of the main reasons why this burden, as it pertains to stroke and non-communicable diseases, is going be out of control. And as occupational health association, what would you like to give, so as to say, like a teeth to the tiger? What is that you would like to propose, so that white collars can have some sort of collective bargaining when it comes to protecting themselves from the long working hours? So those are two questions, sir. The first one was relates to TB, and second one is any sort of steps that needs to be taken in terms of giving power to the organization dealing with white collar problems. Yes, sir.
Thank you, Dr. Akhilesh. Sir, please.
Yeah, Dr. Akhilesh, you raised a very pertinent question. First, regarding tuberculosis. As you know, tuberculosis, the risk factors, and the reason why tuberculosis remains a burden in Africa and Southeast Asia, especially India, is simple. That we are both are in areas which are conducive to development of tuberculosis, especially pulmonary tuberculosis. The reasons are existing burden, poverty, and crowding, and our respiratory hygiene and our practices in relation to disease transmission and immunization as well. The progress that India has made is very substantive. And if you know, this is one of the most important targets that this government has taken up to substantively reduce the burden of tuberculosis from our country by 2023, and which was earlier 2025. So the pace that India has got in terms of reduction is very substantive, and India does contribute almost 1/3 of cases of tuberculosis in the world. The problem will remain as long as we as a country are not able to implement the strategy of adherence to treatment on a substantive basis, on a consistent basis, on a more complete, equitable basis all across the country. And the government strategy is now changing. Almost, you must have seen last 3 years, the progress has been very, very good, and it has been appreciated all across the world. India is a big change maker for tuberculosis control in the world. Regarding second issue, that white collar work versus working hours and the existence of collective bargaining issues. Well, you were right. And in fact, this is precisely the reason that we have now got a new code on occupational safety and health, which is not focused on only hazardous industries. The occupational health standards and the whole structure of occupational safety and health code and the rules made thereunder are focused on having a 360-degree view of occupational health practice in our country, and also moving it towards a universal occupational health service as well as occupational health practice, which is required in our country, with a huge base of agriculture workers, construction workers being there, and who are exposed to the risks. The white collar also, like especially in our country, the service industry, as we are developing, is assuming significant proportions. That also gets covered, including gig workers get covered in the code. So it will be definitely advantageous to move towards the implementation on a fast track basis of these codes and rules thereunder. And especially, I would like to apprise you that now the focus is on occupational health surveillance. We in India did not have any occupational health surveillance system in place on an ongoing basis. So the occupational health data was not fed, the real occupational data was not fed into public health policy or public health practice or allocation of resources. But now that is going to change. The Ministry of Labor has now constituted a committee for improving the occupational health surveillance. And once that system and advantageously, it's now part of the digital health mission. So the IT together with a structured pan-India ground-based occupational health surveillance system, which would be part of our database disease management system, which is already in place, which has shown the advantages in managing the pandemic in our country, shall be a game changer. And that will exactly meet the demand that you are, or expectation that you are making. Regarding long working hours, yes, there is a need for laws and hand-holding by the employers as well as the employees on this issue. And I have given in the last slide the 3 options, 3 action plans that are available. More could be added at the ground level. Thank you for this question.
Thank you so much, Dr. Jan,
Thank you,
for
sir.
the elaborate. Yeah. I've had some query from Dr. Sanjay Rajithor. Dr. Rajithor, please, you can take your question.
Yeah. Good evening, sir.
Good evening, Dr. Sanjay.
Yeah, actually, this was a month-end. Your presentation was a month-end treat for us.
As usual.
Yeah. So when you started, actually, you told we were talking about something underreporting. So looking at the rates of underreported cases, do you agree that it would be 500,000 of deaths underreported in India?
Yeah.
I will cover this topic tomorrow in
Okay.
Rapid updates.
Yeah.
There is some data available,
Yeah.
which is ground level data, actual data available,
Yeah.
and then you will be able to understand what is the implication for our country.
Okay.
There will be some data evidence available tomorrow from
Right.
India on the ground.
Okay. Thank you.
We have a compliment as well as a proposal from Dr. Rendalkar that the work-life balance faced by women employees there needs to be a study. Dr. Jan, it is in Q&A. Whenever you have time, you can answer that how we propose to take it ahead. He has proposed that we should take a different, consider it and take different aspects of it and do some kind of study. That's what Dr. Rendalkar has proposed. And now we have another, yes, Dr. Rendalkar. Yes, please go ahead. Please go ahead, Dr. Rendalkar. Yes, we are, please unmute and you can take up your question.
Okay. Can you hear Dr. Pawan Kumar Gupta?
Yes, I'm Dr. Rendalkar. Good evening, sir. Thank you for the wonderful presentation. Sir, you covered a lot many aspects on occupational health in your talk. There was one aspect which was bothering me. Sir, in this pandemic, we have seen the unorganized sector, and that especially the women folk have been very badly affected. You see in any state, whether they belong to the managerial category, they belong to the the hard working laborers, you find that the women have taken a big brunt of it. The NHS have made a good study on all these aspects. So do we have any avenue where we could study this aspect? Because where a woman has been admitted to hospital or she's been ICU, I had known a case where 2 women working in an organization lost their lives and the family was devastated. So the working women and their status in different parts of India, do we have any study on this matter, sir?
Well, gender issues are an important area, and ICMR is definitely working on this. One important area which good thing about COVID-19 is it's preferentially is attacking more males than females, and the reason is not known. So it is leaving behind females in terms of not only infection but also in severe COVID and number of deaths. That's a scientific fact. The reasons are not known, but it's an epidemiological fact. Gender, all across the World Health Statistics report, you must have seen, I've shown gender as an important factor to be studied, and what the reasons why these gender differences are there need to be looked into further. Let's wait for the results of the studies. You will know more.
Thank you, sir.
Okay.
Thank you.
Thank you. Dr. Thagaraju, you were trying to say something.
Yeah. Thank you, Dr. Pawan Kumar Gupta. Sir,
Thank you
dear
so much, sir.
sir, I just wanted, you said there is a lot of mortality cases in, see, we have seen in this second wave COVID. But the reason is, when we used to see in the TV in the Delhi, so many gurudwaras where they were giving oxygen, this one.
Yeah.
But we see in the developing countries, every COVID patients who are having less than 80 to 90 saturation, there will be 10 doctors and MBBS doctors who will be looking after the 10 beds. And every 6 doctors, 1 physician will be there so that they can report to you. And every MD physician will at least see some 1 or 2 pulmonologists. Because why I am telling is, most of the developing countries hospitals, they have done pulmonary angiogram, and they have aspirated this mucus from the bronchoscope, and patient has remarkably improved. But unfortunately, what happened, when we give oxygen by layman, we are unnecessarily, we are putting a lot of complication into the lungs. Second thing is, when we give industrial oxygen to the this one, this is also one of the cause for mucormycosis. And second thing is, this most of the people, they have not even washed this whatever the mask, and this is also one of the cause. And as a diabetology, this one diabetic foot, I see a lot of the cases of diabetic foot. I have seen gangrene. I have never, and these patients who have admitted in the COVID ward also, but they have never developed foot mucormycosis. They are diabetic, they have been given steroids, they have been given oxygen, but they have not developed any mucormycosis. It is only this one, the contributing factor are many more. That is. Second thing is, when we have found so much mortality, our Rajiv Jain sir wonderfully explained so much mortality, so many things, and I think we have somewhere something we have not utilized the pulmonary angiogram, pulmonologist, because there are wonderful gold standard treatment is there in pulmonary fibrosis like Ninitab and Piriferidone. So many wonderful drugs are there. I think in the costliest hospitals only, in a private hospitals only, I mean the corporate hospital only, these things given. In government hospitals, we have not seen this kind of drugs. When they come out with 60, I think mortality is 100% chances were there. When you admit in a government hospitals, even in All India Medical Sciences, when we saw there are so many deaths like Agarwal and all, Dr. K.K. Agarwal and all, we have seen. I think this one, I think Dr. Rajiv Kumar Jain sir, you please throw some light, and you also should come out with certain article so that our government, we can present it to the government, we can present it to the responsible person, that henceforth in third wave or anything, this kind of tragedy should not occur, this kind of mortality should not be high. Wherever this kind of, wherever we can treat, we have not treated and properly. Thank you, sir, for giving me an opportunity, Dr. Pawan Kumar Gupta. And this is my And I just wanted one of the best, as you said, is the international speaker, Dr. Rajiv Jain. I wanted to hear from his mouth that what he exactly wanted to tell about it.
For sure, Dr. Tyagaraja. Thank you so much for your kind words. Over to Dr. Jain, please, sir.
Well, Dr. Tyagaraja, thanks for the nice words. The issues that you have highlighted are under examination at various levels in our research institutions and our apex medical institutions. And let us wait for the consensus and the evidence to emerge. And you must have seen the evolution. One of the confounding factors, most important confounding factors has been the variance issue, variants of concern that have come up, especially B16172, which has caused real havoc in UK and India, and it is now spread to 53 countries. That is a compound factor which was very difficult to predict. The virus evolves, and virus is evolving very, very fast than we can imagine. And in addition to that, the factor of vaccination and COVID appropriate behavior adherence by the population, the number of issues are there. In the months to come, we will know better. The issue about third wave is still under examination. Let's go wait for this wave to be managed effectively across the country, and let's see the results of unlocking in state after state. Let's hold our judgment for later, I believe. We are trying our best to manage with the kind of constraint that we have, to the best of our resources.
Thank you, sir. Thank you.
Yeah. Thank you so much, Dr. Jain. I cannot see any more hands or queries here, but the floor is open. If anyone has any queries or suggestions or questions, please feel free to share your thoughts.
Dr. Shyam Pingle is there. Dr. Divyank Shah, I also see.
Yeah. Yes. Yes.
Thank you, Dr. Jain. I have no questions today. I'll reserve them for tomorrow. But excellent presentation as usual. And you bring to us so many sources and so many things. So that is really helpful. Thank you.
Thank you so much, Dr. Pingle.
Dr. Divyank, want to say?
Yeah, nice to hear you every week, sir. And this was again a refresher course for me for just correlating the diet, nutrition, and pandemic. It was again a basic safety, food safety, and your lucid presentation. And heads of you to gather the information for us and keep us the live CME, and we can percolate to our organizations. Thanks again, sir. Thank you very much.
Thank you.
Thank you very much, Dr. Shah. With that, I think we have come to the end of the session and end of today's 6th series of OcuHealthscape. I really thank from core of my heart once again to Dr. Jain for elaborating, bringing such informative and wonderful thoughts to us. I really appreciate your gesture, and thank you so much to all of you for participating, putting across your query and wonderful discussion.
I'm thankful to all of you to have the patience for this last 1.5 hours. And if you would like to share from YouTube, we will send on WhatsApp the link from the YouTube. The recording would be available through YouTube. You can share the recording, and the soft copy of the presentation would be available in the WhatsApp groups. Thank you so much for all your time.
Thank you so much, Dr. Jain.
Thank you.
Thank you.
Thank you so much. Thank you.